Hello friends, lymph node biopsy is one of the most challenging areas in pathology. Reactive hyperplasia, infections, lymphoma, many entities can look deceptively similar. If you don't follow a structured approach, it's very easy to make a mistake. In this video, I will give you a step-by-step diagnostic algorithm so you can confidently approach any lymph node biopsy, both for exams and real-life practice. Every lymph node biopsy should be approached in 5 steps. First, architecture. Second, cell population. Third, necrosis and granulomas. Fourth, specific diagnostic clues. Fifth, immunohistochemistry. Well, if you follow this sequence, the diagnosis becomes much simpler. Step 1. Architecture. First, always assess the architecture. It's preserved, then it is usually reactive. If the architecture is effaced, think lymphoma or metastasis. Look at the follicular patterns. Are the follicles variable in size or uniform? It is very important because sometimes reactive hyperplasia can closely mimic follicular lymphoma. But there are subtle clues which can help you differentiate between the two. Those clues are: in follicular lymphoma, you will see that the architecture is effaced and there is uniformly sized follicles with monomorphic cells and loss of mantle zone. However, in reactive hyperplasia, you will see variably sized follicles with preserved mantle zone, polymorphous population of cells, and tingible body macrophages will be present. So, if follicles look too uniform, always suspect lymphoma. Step 2, cell population. So next is the cell population. If the cell population is polymorphic, it can be reactive. And if the cell population is monomorphic, it could be a lymphoma. And if there are foreign cells present, you should always suspect metastasis. Monotony is malignancy until proven otherwise. Step 3, look for necrosis patterns. If you see necrosis, just don't stop, classify it. Cause in Kikuchi Fujimoto disease, you see necrosis with keratoctic debris but no neutrophils. So here, necrosis without neutrophils is a key clue. In tuberculosis, you will see caseating necrosis with granulomas and presence of Langerhans giant cell. Also here, when you see these, you can do a AFV stain or ZN stain to demonstrate the acid-fast bacilli. In cat scratch disease, the pattern of necrosis is delayed type and there are suppurative granulomas. So, always ask caseating, suppurative or no neutrophils in the necrosis areas. Step 4, granulomas. Look for non-caseating necrate granulomas, and if they are present, then this gives you a clue about sarcoidosis. However, as I have told you earlier, if the granulomas are caseating, there is presence of Langerhans giant cells, there is presence of acid-fast bacilli, think about tuberculosis. So, caseation suggests tubercular infection and clean granuloma suggests sarcoidosis. Next, if you are suspecting any fungal infection, there are 3 main fungus which you can encounter in the lymph node biopsy: histoplasmosis, cryptococcosis, and aspergillosis. The histoplasmosis, you will see intracellular yeast forms. In cryptococcosis, you will see capsulated yeast, and in aspergillosis, you will see acute angle branching of the aspergillus. Always confirm it with special stains like PAS and GMS. Next criteria is specific morphological clues. For example, in Castleman disease, you will see the lollipop appearance, which is hyalinized vessel plus onion skin mantle zone, giving it a lollipop appearance. In angiolymphoid hyperplasia with eosinophils, you will see prominent vessels with eosinophils. Now comes a critical step, Identifying Reed-Sternberg cells. In Hodgkin's lymphoma, Reed-Sternberg cells are present and there is mixed inflammatory background generally. So, if you see few tumor cells, which are RS cells and lymphoid background or a mixed inflammatory background, think Hodgkin lymphoma. In non-Hodgkin lymphoma, there is no true RS cells present and there is monomorphic population. RS-like cells can be seen, but context is everything. Step 6. Immunohistochemistry. Morphology gives suspicion, especially in cases of lymphomas, but in the immunohistochemistry gives confirmation. The lineage markers more specific for B-cell lymphomas are the CD20 markers, and CD3 is the most important lineage marker for T-cell lymphomas. Classical Hodgkin lymphoma is CD15 positive, CD30 positive, and there is negativity for CD20. However, nodular lymphocyte predominant Hodgkin's lymphoma is CD20 positive and CD15 negative and CD30 negative. So, CD20 positivity does not rule out Hodgkin's lymphoma. If Ki67 index is high, they denotes an aggressive form of lymphoma, and if it is low, then indolent course of lymphoma. So, always remember architecture, cell population, necrosis and granulomas, specific clues, presence or absence of Reed-Sternberg cells, and lastly, confirmation with immunohistochemistry. Lymph node pathology is not just about memorizing diseases. It's about recognizing patterns. Once you understand the pattern, the diagnosis becomes obvious. Well, if this video has helped you, I will be continuing this approach to diagnosis series. Let me know which topic you want next. Thank you and bye for now.